Welcome to this DermNet e-lecture on skin and systemic disease, which will be delivered by Dr. Ian Coulson, the editor of DermNet. The skin is a visual window into the clues of systemic disease, and recognizing these cutaneous manifestations of systemic disease can aid diagnosis and appropriate treatment in a timely manner. However, this is quite a vast topic, and 2-volume books have already been written in skin and systemic disease. It's a very important topic, and therefore in this e-lecture we will cover the common and rarer but important conditions, and we hope through this e-lecture to stimulate your interest, and if you want to look up more specific details, you can refer to the DermNet pages for further details, photographs and management. Through this talk, we hope you'll have a better understanding of the skin and systemic disease across a variety of different specialties. Therefore, we have split them up into specialty systems outlined below. So we will cover the cutaneous manifestations associated with endocrinopathies, rheumatology, renal, haematological and metabolic disorders, gastroenterology and hepatology, nutritional, genetic and dermatologic associations.
Hormones can have quite a profound effect on the skin. So in the next few minutes, we're going to discuss the skin changes that we see in diabetes, in thyroid disease, in adrenal disease, and cutaneous aspects and endocrine aspects of hirsutism. 30% of diabetic patients will experience skin problems during the course of their disease. Several of these are common conditions which occur in normal individuals but are more common in those with diabetes, particularly candidal infections, particularly in the intertriginous areas and on the genitals, and impetigo. There are some conditions which are almost unique and specific to diabetics. One of these is a condition called necrobiosis lipoidica. So this occurs in about 1% of patients with diabetes, and it tends to occur unilaterally or bilaterally, often asymmetrically affecting the anterior aspects of the shins. It's more common in women with diabetes. The cause is unknown, but it is associated with microvascular disease. We usually make the diagnosis clinically. How do we recognise necrobiosis? Well circumscribed, often orange, red lesions, as I say, maybe unilateral or bilateral, but as the lesions progress, they often develop a central atrophy. And as you can see in the lower image, the lesions often have this yellowish colour, and quite commonly it's possible to see enlarged telangiectatic vessels underneath the skin. Here are some more images of necrobiosis. Again, in the upper panel you can see a rather irregularly marginated plaque, erythematous rim, central atrophy, and you can see quite a large vein easily visible underneath it. In the lower panel you can see that the area has ulcerated, so the shins are very susceptible to trauma and necrobiosis will ulcerate. How do we treat it? Try and maintain a really efficient control of the diabetes, discourage smoking, which always makes necrobiosis worse and tends to allow it to ulcerate. They can be treated with intralesional topical steroids. There are other treatments that we use, such as photochemotherapy. So it's a chronic condition, and we try and stop it spreading, because once it's present, it atrophies, and it's both a functional and a cosmetic nuisance. Another condition which we see, which is allied to diabetes, is a condition called acanthosis nigricans. So this is a condition which produces rather brown velvety patches both on the neck, but particularly in the axillae and also the groins. It's caused by insulin resistance, which of course is more common in the obese and those with type 2 diabetes. And the reason for this is that insulin crosses the dermoepidermal junction and binds to type 1 insulin-like growth factor receptors on keratinocytes, and this stimulates the growth of keratinocytes, which produces both hyperpigmentation and this rather velvety appearance. There are other causes, so there are metabolic disorders such as polycystic ovary syndrome, the metabolic syndrome. Obviously, obesity is the most common cause, and we do see it occasionally in autoimmune diseases such as systemic lupus and scleroderma. Rarely it can be associated with underlying malignancies, and these tend to be malignancies which produce epidermal growth factors, which also will stimulate keratinocytes. But usually people who have malignancy-associated acanthosis are thin rather than being overweight. Here you can see the clinical features of acanthosis nigricans in the groins. The skin is hyperpigmented, thickened and velvety, and there are a number of skin tags which are often seen in the presence of acanthosis nigricans. So acanthosis nigricans occurs axilla, groin, back of the neck. If we see it more extensively than that, and particularly if there's similar changes in the mucous membranes, and particularly if a patient is underweight rather than obese, they're the features that would make us think about malignancy-associated acanthosis nigricans. The areas are often macerated and malodorous and sometimes itchy. More images of acanthosis nigricans: thickening, hyperpigmented, and lichenified skin in the groins, and in the lower panel you can see a magnified dermatoscopic image showing this rugose appearance. How do we manage this? Well, treat the underlying cause. Try and lose weight, treat diabetes, reduce insulin levels with metformin. There are some specific topical agents that can be used, such as keratolytic agents, salicylic acid, glycolic acid, topical retinoids, vitamin D analogues. Obviously, the outcome will depend on the cause. A condition that is occasionally associated with diabetes is granuloma annulare. So this produces slowly spreading rings, and the back of the hands and the top of the feet are quite common sites, but it can occur more generally, as you can see in the lower panel. But the margin of the lesion is composed of little non-scaly papules which arrange themselves to produce the ring, and you can see the ring-like nature at the base of this man's thumb on the upper image and on the edges of the lesions on this lady's thighs. So annular, smooth, slightly discoloured papules producing this ring-like appearance. As I say, it may be localised, may be generalised. There is a relatively weak association with diabetes, and occasionally it's seen in the setting of HIV, and also other conditions more rarely, such as thyroiditis, lymphoma, solid tumours, HIV as mentioned before. So we obviously ought to exclude fungus, which is quite commonly misdiagnosed. So the way to do that is to take some scrapings. Granuloma annulare is usually non-scaly, whereas a fungal infection is usually scaly. And if there's any diagnostic doubt, you can take a biopsy from the margin of the lesions when the histology of granuloma annulare is quite characteristic. It can regress of its own accord, but if not, we can treat it with topical steroids, intralesional steroids, if it's very extensive, oral retinoids or phototherapy. Another thing which is quite commonly seen in diabetics is called diabetic dermopathy, sometimes called pigmented pretibial patches or diabetic shin spots. So they tend to occur on the shins, small brown macular patches. They can resemble solar lentigines, No treatment's really required, but it is a marker of underlying diabetic microvascular disease, and it occurs in about 30% of people with long-standing diabetes. Skin infections are more common in individuals with poorly controlled diabetes. Skin infections are covered in another e-learning module in detail. But in the lower panel here you can see a diabetic with submammary candidiasis. So you can see it's red, glazed, but one of the hallmarks are these little satellite pustules which occur around the outside. You can see there's candida present on the buccal mucosa, and in the upper panel you can see a candidal infection of the nail plate, all more common in diabetics. A condition called erythrasma, caused by the bacterium Corynebacterium minutissimum, is more common in diabetics. It tends to produce flexural eruptions, so in the axillae, in the groins, sometimes in the toe webs. The causative organism will produce porphyrins, and these can be identified by looking at the affected area in the dark with Wood's light examination, a UVA lamp, and the areas fluoresce. And erythrasma is covered more in the skin infections module. The skin is quite commonly affected in aberrations of thyroid function. In hyperthyroidism or thyrotoxicosis, the skin is often warm, moist, and smooth. There may be facial flushing and palmar erythema. There may be hyperpigmentation of the palms and soles, but you don't tend to see hyperpigmentation of the mucous membranes. There may be hair thinning. The hair may become fine, friable, and a diffuse alopecia may develop. And there may be hyperhidrosis, increased sweating of the palms and soles. In contrast, in hypothyroidism or myxedema, the skin is cool, pale and dry, and maybe very slightly scaly. There may be hypohidrosis. Occasionally there is thickening the palms and soles in hypothyroidism. This is called a palmoplantar keratoderma. Due to elevated levels of beta-carotene that can occur in hypothyroidism, carotenemia may develop, which produces an orange-yellow hue, particularly the palms and soles. In hypothyroidism, the hair may become dry, brittle and coarse, and there may be a diffuse alopecia. But one thing that is noticed in hypothyroidism is sometimes the lateral third of the eyebrows will be lost. The nails will grow slowly, they'll be brittle, there may be ease of bruising, and there may be impaired wound healing. One of the specific conditions that occurs in thyroid disease is a condition called pretibial myxedema. Now, this tends to occur in people with hyperthyroidism due to the effect of long-acting thyroid stimulator producing an increased amount of mucin within the skin, and it tends to occur on the lower half of the shins. The accumulation of mucin produces thickened plaques in the affected areas, and if one was to biopsy the area, one would find that the dermis is filled with mucin. It occurs in anywhere between 1 and 4% of patients with Graves' disease. It's often asymptomatic, as previously stated, often bilateral, firm, non-pitting, edematous features. The skin becomes eventually thickened and hardened and will have a peau d'orange appearance. It often has a yellow-brown tinge, and there may be associated overlying hyperhidrosis or hypertrichosis. So it's one of the specific features of either previous or current hypothyroidism. The nails may be affected in hypothyroidism, and we sometimes see a triad of digital clubbing, soft tissue swelling of the hands and feet, and periosteal new bone formation may be identified on X-ray. And this triad is called thyroid acropathy, and it's often associated with hypothyroid disease, exophthalmos, and pretibial myxedema. So thyroid acropathy, digital clubbing, soft tissue swelling of the hands, periosteal new bone formation. Skin symptoms and signs are common in individuals with adrenal insufficiency or Addison's disease, and they're very often presenting symptoms. Most people with adrenal insufficiency have autoimmune destruction of the adrenal glands, but globally, tuberculosis of the adrenal glands is a not uncommon cause of Addison's disease. Loss of adrenal tissue leads to an increased secretion of ACTH, and this produces increased pigmentation. So patients with Addison's disease have low levels of cortisol, high levels of ACTH, and this produces pigmentation both of the skin, nails, and mucous membranes. So in the upper image you can see a lady who presented with Addison's disease with pigmentation of a lips and the side of the tongue. The picture of the nail shows a longitudinal pigmented band, and in the man in the bottom panel you can see that there's hyperpigmentation secondary to Addison's disease, particularly over the knuckles. More examples of Addison's disease, again, hyperpigmentation over the knuckles seen on the hands, and genital increased pigmentation is very common both in men and women. Autoimmune Addison's disease is fairly commonly associated with vitiligo, and this patient's got long-standing vitiligo, but this was becoming more evident because the surrounding non-vitiliginous skin is developing increased pigmentation, so the vitiligo appears to be becoming more evident. How do we diagnose Addison's disease? Well, clinical features, they're often losing weight, feel tired and exhausted, and you'll find that they've got postural hypotension. But the definitive test is a short synacthin test. So they're given synacthin and their cortisol response is severely blunted. And obviously they need endocrinology referral and mineralocorticoid and glucocorticoid replacement. Hypercorticism produces the features of Cushing's syndrome. And obviously Cushing's syndrome can be due to exogenous production of glucocorticoids from either a pituitary adenoma, more commonly an adrenal adenoma. And of course it's most commonly caused by exogenous steroids used to treat another disease. So what features do we see in the skin? So we'll see poor wound healing, skin fragility and purpura, hirsutism, acne-like eruptions, particularly over the chest and back, cutaneous atrophy and telangiectasia, and striae. More generally, of course, there'll be truncal obesity, a moon face, and a buffalo hump over the nape of the neck. So these are all features of hypercorticism or Cushing's disease. Hirsutism is defined as a male pattern of secondary or post-pubertal hair occurring in women, so the development of terminal hair and a male secondary sexual distribution, in contrast to hypertrichosis, which is an increase in the amount of terminal hair in a non-secondary sexual distribution. So only women will develop hirsutism, but both men and women can develop hypertrichosis. So in women, hirsutism most commonly arises in the moustache and beard area at puberty. It tends to be more significant and particularly might point to more serious underlying disorders if it occurs acutely, and other areas are involved, such as the chest, back, and shoulders. Hyperandrogenism is often associated with polycystic ovaries, and that's probably the most common cause of hirsutism, but it can occur with insulin resistance and obesity. Of course, it can occur with the ingestion of androgenizing medication. More rarely, it can occur in the setting of congenital adrenal hyperplasia and androgenizing tumours of the ovary or adrenal gland. So here's an example of significant hirsutism which has developed in a middle-aged woman. And this was due to an underlying adrenal androgenizing tumour. So you can see there's male pattern baldness, there's hirsutism affecting the face, but there's also terminal hair over the shoulders, the upper arms, chest and abdomen. So obviously this would be indicative of a much more severe type of hirsutism and was associated with an underlying functional hormone secreting tumour. In the next section we're going to cover some of the skin changes that are seen in rheumatological disorders. Now some of these conditions are rare, but they're important to recognise because they have serious consequences. So we're going to cover conditions that affect collagen and elastin, such as Ehlers-Danlos syndrome and pseudoxanthoma elasticum, discoid and systemic lupus, dermatomyositis, systemic sclerosis and vasculitis. Ehlers-Danlos syndrome is actually a number of conditions, at least 14, where there is a genetic defect in collagen or connective tissue synthesis and structure. But in general, this results in fragile and hyperelastic skin, unstable, hyperextensible joints, and sometimes fragile tissue and blood vessels. So there are many subtypes, but one particular, Ehlers-Danlos syndrome type 4, is very important, rare, but has serious implications to the affected individual. So this girl presented at the age of 23 to the surgeons with an acute abdomen. She had a laparotomy, and this showed that she'd had a spontaneous rupture of her cecum, for which there was no otherwise explicable explanation. But it was noted that she got the following features. On her face, you can see there's a scar just above the glabella. She's got a slightly bulbous nose, quite a long philtrum, and rather thin lips. You can see on the side view of her face that she has got a lobeless ear. You can see also that she bruises very easily, and she's got hyperextensible joints. She's got rather long, spindly fingers, and her skin has a prematurely aged appearance. You can see the blood vessels under the skin relatively easily. You can also see that she has got these rather unusual, patulous, rather broad scars from previous history of trauma. And these are all the features of type 4 Ehlers-Danlos syndrome. And this is a condition whereby not only do you have cutaneous features, but there are important internal features, the most important of which is that individuals are susceptible to dissecting aneurysms of their major vessels. So they sometimes present with a ruptured or dissecting aortic aneurysm. They also have quite serious problems during pregnancy and after delivery, and are susceptible to severe postpartum hemorrhage. So this is the most important type of Ehlers-Danlos syndrome, type 4, because it's a killer. So important to recognise because there may be major vessel dissection, and because of this they have to be on lifelong beta blockers, and this has been shown to significantly reduce the chances of aortic dissection and rupture. As this girl presented, they can get abdominal viscous rupture and severe obstetric complications, severe postpartum hemorrhaging. Pseudoxanthoma elasticum, again, is a relatively rare inherited condition. This time it's an inherited condition of elastin. It's an autosomal recessive disease, and the gene encoding for this has been identified. It leads to progressive deposition of calcium and phosphorus on elastic fibres, which alters their function and allows the elastin to rupture more easily. The features we see in Pseudoxanthoma elasticum in the skin, the best place to identify PXE is on the neck, and it produces little flesh-coloured to yellow papules, which give particularly the skin on the neck a so-called plucked chicken skin appearance. Similar features can be seen in the antecubital fossa. You can see this lady here, the slightly yellowish discoloration due to small dermal coalescing papules. So these are the skin features of Pseudoxanthoma elasticum. It's called pseudoxanthoma because the yellow colour will mimic true xanthomas. The skin can be lax and wrinkled, and there are important internal manifestations. One of the biggest causes of morbidity is ocular disease, because Bruch's membrane at the back of the retina, which supports the retina, will rupture, and it can produce things called angioid streaks. So on this ophthalmoscopic image, you can see highlighted with the arrows grey-blue structures which mimic blood vessels, but in fact they're actually due to ruptures in Bruch's membrane. And loss of this support gives an increased tendency to retinal detachment, and blindness is one of the more common problems to occur in PXE. People with PXE also tend to have angiodysplasia in their gut, so they often present with unexplained iron deficiency anemia or melena. So Pseudoxanthoma elasticum. Lupus erythematosus is an autoimmune disease, and the skin is frequently involved in this condition. So we see a condition called discoid lupus, where the lesions are confined to the skin with a very low instance of progression to systemic disease. We see another variant called subacute lupus. So this tends to produce non-scarring red scaly lesions which are often annular, present over the chest and back. Again, there's a relatively low risk of systemic disease, but the condition is often drug-induced, and affected individuals often have antibodies directed towards anti-Rho and anti-LAR. Systemic lupus is a condition where not only is the skin likely to be involved, but the joints, kidney, lung and brain may also be affected, and this is associated with strongly positive anti-nuclear antibodies and anti-double-stranded DNA antibodies. So a spectrum of disease going through from discoid lupus, which tends to produce localized skin lesions which scar, subacute lupus, more extensive lesions which are often annular, may resolve without scarring with a low incidence of progressing to systemic disease, and systemic lupus, where not only is the skin affected but other organs which may be life-threatening are affected, such as the kidney, lung, brain and joints. So here are some examples of discoid lupus erythematosus. This tends to produce discrete, red, scaly, initially papules, which extend out to produce plaques, most commonly on the face, neck, and scalp. At first, they may be intensely red and inflamed, but as the condition continues, it will produce scarring. And if this happens in the scalp, there'll be loss of hair, and particularly in dark-skinned people, there'll be dyspigmentation. So on the upper right-hand panel, you can see a very well circumscribed erythematous plaque on the nose, but if you look carefully, you can see these little follicular excrescences, what are termed follicular plugs. Now, here's an example of a relatively common presentation of cutaneous lupus. This is called subacute cutaneous lupus erythematosus. So lesions tend to occur on the light exposed areas, the V area of the chest, the face, light exposed areas on the arms. The lesions are often annular and slightly scaly. They're often made worse by sunshine and more evident during the summer months, may even regress during the winter. Often associated with Sjögren's syndrome. Subacute lupus can occur of its own accord, but very frequently it's triggered by drugs, and there are probably about 60 different drugs that have been reported to induce subacute lupus. But thiazide diuretics, calcium channel antagonists, proton pump inhibitors, and terbinafine are all fairly well known. Again, there is a relatively low risk of this progressing to produce systemic disease with the lung, kidney, or brain being affected. Systemic lupus erythematosus is a potentially fatal condition, obviously caused by autoimmunity. Skin lesions are present in about 80% of people. So the most common cutaneous signs are of a facial eruption, which tends to be made worse by sunshine and tends to occur in the sun-exposed sites, so particularly on the face, upper arms, backs of hands. Sometimes referred to as a butterfly rash, erythematous plaques arising over the cheeks and extending sometimes down onto the neck. There may be an associated alopecia, which may be scarring or non-scarring. The hair may be rather unruly and thin, sometimes referred to as lupus hair. There may be mucosal ulceration in systemic lupus. Very commonly there are dilated nail fold capillaries. And there may be evidence of underlying vasculitis. So this might present with a palpable purpura, particularly on the lower limbs, or with medium-sized vessel vasculitis producing livido reticularis. Now, the diagnosis is aided by various lupus classification systems, which involves features in history, examination, and immunology. So the important thing is to recognize systemic lupus, identify if other internal organs are affected, particularly kidney, lung, blood vessels, joints, and treat accordingly. Skin lesions tend to be treated by photoprotection, sunscreens, keeping covered over, topical therapy, that is potent topical steroids, or calcineurin antagonists such as Protopic. And obviously, with any evidence of internal disease, systemic therapy with, for example, antimalarials such as hydroxychloroquine, or immunosuppression with azathioprine, methotrexate, mycophenolate, etc. Dermatomyositis is an inflammatory condition which tends to affect the skin and muscles, though sometimes the skin only is affected. Its importance is that although it's rare, the muscle involvement can progress quite quickly and produce both difficulty in swallowing and aspiration pneumonias and respiratory failure. Dermatomyositis can occur in childhood, but when it occurs in adults, it's quite commonly associated with the presence or development of an underlying malignancy. There are now a number of myositis antibodies that have been identified, and some of these do give an indication of the kind of problem that may develop. So if people have got antibodies against an antibody called TIF1 gamma, we know that they are more likely to develop an underlying malignancy. Individuals who've got anti-Jo antibodies may develop interstitial lung disease. So what are the cutaneous features of dermatomyositis? Well, it can produce a purple redness, particularly over the forehead, cheeks, and the V area of the chest. And very commonly there is slight swelling of the skin, most easily visible over the lids. The affected areas are photosensitive, so the rash tends to get worse with sunshine. There's sometimes a similar violaceous eruption over the upper back, which is called the shawl sign. The facial eruption is sometimes termed heliotrope or heliotropic, and that's because a heliotrope is a purple alpine plant, and the rash has this purple violaceous hue. We almost always see signs on the hands in cutaneous dermatomyositis, papules around the nail folds and over the knuckles. So these are called Gottron's papules. It's very important to look carefully at the nail folds because the cuticles will be ragged and you may see distended, dilated blood vessels. Now, myositis is the really serious problem that can occur in dermatomyositis. So initially this is a proximal myopathy, so patients may volunteer they're having difficulty getting up from a chair, sitting up from lying, but then they may develop more extensive muscle weakness, so this can affect the muscles of swallowing, leading to aspiration pneumonia, or can affect the respiratory muscles, leading to respiratory failure. And this can come on quite quickly and quite acutely. In some cases of dermatomyositis, particularly associated with the Jo1 antibody, there's pulmonary fibrosis, and occasionally the cardiac muscle is affected, producing a myocarditis. Systemic sclerosis, again, is a rare condition, but it can have life-threatening implications to those that are affected. We often divide them into two: limited cutaneous systemic sclerosis and diffuse cutaneous systemic sclerosis. So with limited disease, there's often a background of increasingly severe Raynaud's phenomenon, and then the development of what is called sclerodactyly. That is, the skin on the, particularly over the fingers and hands, becomes thickened and stiff, so it's difficult for people to move their fingers, particularly make a fist. There may be telangiectasia, particularly around the mouth. And eventually, calcification can occur, particularly in the finger pulps, and you can see that in the lower left-hand panel. There's calcium deposition in the thumb pad. Systemic disease, again, there'll be sclerodactyly, abnormal nail fold capillaries. But stiffening the skin around the mouth makes the mouth go smaller and difficult for individuals to completely open their mouths. Tightening of the skin over the nose will produce a beaked deformity. Again, there'll be calcinosis peripherally, and there may be dyspigmentation with salt and pepper colour changes, particularly in individuals with darker skin types. But the important thing is that internal involvement can occur. So this can affect the esophagus, so there's difficulty in swallowing. It can affect the lungs and also the small bowel. So again, we've gone over this relatively superficially. If it's of interest to you, look it up in detail on the DermNet pages. Vasculitis, or inflammation of the blood vessels, is a complicated topic, but it can be classified by the size of blood vessel involved. So if the capillaries are affected, it produces a condition called capillaritis, and this can affect the skin and tends to produce what are called pigmented purpuric eruptions. Perhaps the commonest type of vasculitis we see will be small vessel vasculitis, and that presents as palpable purpura. Medium vessel vasculitis is caused by a condition called polyarteritis nodosum, Kawasaki's disease, or nodular vasculitis. And these often present, particularly polyarteritis nodosum, as livido reticularis, a dark purple net-like appearance to the skin. Large vessel vasculitis, such as giant cell arteritis and Takayasu's disease, usually doesn't affect the skin. And here are some clinical examples of various types of vasculitis. So in the upper panel, typical place to get small vessel vasculitis is around the ankles and lower legs, because it tends to come out in areas of dependency, produces palpable purpuric lesions, and sometimes you get hemorrhagic blisters in the centre of these lesions. In the middle panel, you can see a good example there of fixed livido reticularis, a vivid, deep purple coloured eruption in a net-like distribution. In the lower panel, we can see how large vessel vasculitis can occasionally affect the skin. So this unfortunate lady developed temporal arteritis, and as a consequence of this, she got skin ulceration. So vasculitis, a very large and complicated topic, and I think the idea is to get the general principles of what vasculitis looks like in different sized blood vessels. The skin can be affected in a renal disease. The commonest condition we see is xerosis, or dryness of the skin, particularly in those undergoing long-standing renal dialysis. Itch can be a presentation of renal disease, or can be a problem in long-standing renal failure. One of the most serious skin complications that occurs with long-standing renal disease, particularly end-stage renal disease in people undergoing dialysis, is a condition called calciphylaxis, where there's calcification of the small arterioles and smaller arteries in the skin, producing ulcers. It carries a very poor prognosis. So here's examples of xerosis in chronic renal disease. The skin is dry, rough and scaly, and as a consequence the skin is often quite itchy. How do we manage this? Avoiding soaps and detergents, and the liberal use of emollients, both in place of soap, particularly after bathing, and at any time if the skin is dry. And this can be useful to treat and will help diminish symptoms. Severe itch affects up to about a third of people having renal dialysis. It usually occurs on the forearms and back, and at first the skin might appear normal or may just be excoriated, but eventually we'll see prurigo lesions and lichen simplex due to chronic scratching. The itch is often worse at night and will be exacerbated by heat and stress. So a common and sometimes disabling complication of renal disease, particularly those undergoing dialysis. How do we treat it? Again, moisturising creams. Localised areas can be treated with topical capsaicin. Ultraviolet light can be useful, and then we might need to use systemic agents such as antihistamines, cholestyramine if high bile acids are a problem, and even agents such as naltrexone, the opiate antagonist. But transplantation is the definitive treatment for severe disabling renal dialysis itch. Calciphylaxis is one of the feared complications of end-stage renal disease, particularly in those undergoing dialysis. It results from calcification of the small arteries in the skin, but calcification also occurs in other internal organs. It'll present as areas of livido reticularis, so a reticulate, livid eruption which is tender, and fairly quickly that will extend and ulcerate, producing gangrene. It carries a very poor prognosis. It needs management with meticulous wound care, and occasionally sodium thiosulfate infusions are used to try and dissolve the intravascular calcification. So calciphylaxis, a feared and often fatal complication of end-stage renal disease. In the next few slides, we'll discuss the interesting conditions of the cutaneous porphyrias. So the porphyrias are metabolic conditions which occur due to enzyme deficiencies involved in the synthesis of heme. Deficiency or block of one of these enzymes results in a buildup of the corresponding precursor, and buildups of these porphyrins can result in skin problems. Now, the commonest porphyria that we see is called Porphyria cutanea tarda, and it's due to low levels of the enzyme uroporphyrin decarboxylase. There's often an inherited predisposition to this condition, but it's brought out by various toxins, including alcohol, hepatitis B and C, HIV, hemochromatosis, iron overload due to supplementations and transfusions. It can also be seen occasionally in dialysis patients who can't excrete the relevant porphyrins effectively. So how does it present? Well, it tends to occur with an eruption, particularly on the back of the hands. There is fragility of the skin of the back of the hands, which tends to produce ulcers and sometimes even blisters. These blisters are often initiated by intense sunshine exposure because the porphyrins are photosensitive. So the blisters will often rupture and they'll heal over, leaving tiny little white cyst-like lesions called milia, and they can be seen over the knuckle in the middle panel. Other changes can occur, so we can sometimes see hypertrichosis, particularly over the forehead and cheeks, and sometimes due to chronic high levels of uroporphyrin, we can see scleroderma-like changes, particularly on the light exposed areas, and even areas of hair loss as a consequence. So Porphyria cutanea tarda, the commonest cutaneous porphyria, produces fragility and blistering on the back of the hands, exacerbated by sunshine. Blisters will often heal, leaving scars and milia, maybe associated hypertrichosis and scleroderma-like features. The second most common cutaneous porphyria is called erythropoietic protoporphyria, and this is due to deficiency of the enzyme ferrochelatase, and this is the enzyme that adds iron to heme. Deficiency of this enzyme produces high levels of something called protoporphyrin. Patients with this condition, which often runs in families, it's dominantly inherited, may present in childhood with photosensitivity and pain and swelling due to light exposure. So often at first there's no signs, there's just symptoms of pain on exposure to sunshine. Over the course of time, and particularly after intense sunshine exposure, there may be redness, swelling, very occasionally blistering and crusting. Over the years, the skin will become thickened, particularly over the dorsal aspects of the hands, and often furrows develop on the upper lip. There's no cure. The treatment of this condition is photoprotection. Various agents have been used to try and help, such as beta-carotene and also alpha melanotide, which is used to try and produce a pigmentation of the skin by inducing melanogenesis using a synthetic MSH. The other problem is that patients with erythropoietic protoporphyria can develop porphyrin stones, which tend to develop in the gallbladder, and a small proportion of people do develop a liver failure. There are some important skin conditions that occur within the arena of gastroenterology and hepatology. So pyoderma gangrenosum, we not uncommonly see in the setting of inflammatory bowel disease, Crohn's disease. Obviously, jaundice may present with yellowing of the skin. Chronic liver disease may produce spider nevi, telangiectasia. We'll see palmar erythema with liver disease. Henoch-Schönlein purpura is actually a small vessel vasculitis, but this often occurs in the gut, producing gut and skin symptoms. Dermatitis herpetiformis is an immunobullous disorder which is always associated with gluten-sensitive enteropathy. Pyoderma gangrenosum is an ulcerating condition which is often associated with inflammatory bowel disease and occurs in up to 2% of patients with ulcerative colitis, but it can occur without any obvious underlying associated pathology, but it will occur in the setting of seronegative arthritis, myelodysplasia and leukemia, and particularly IgA paraproteins. So inflammatory bowel disease is the best recognised and most common underlying condition, but not the only one. How does it present? Well, initial lesions will start as a red, inflamed area and possibly a pustule, but this will then break down and produce sometimes a fairly rapidly extending ulcer. The ulcer edge is often swollen, purple, and often undermined. And pyoderma gangrenosum can occur after trauma, particularly surgical trauma to the skin. So in the bottom panel, you can see a lady who has had surgery for a breast reconstruction, and the flap that was taken from her abdomen broke down to produce a rapidly extending ulcer, which eventually affected all of her abdomen. And this was eventually put down to pyoderma gangrenosum, and she needed immunosuppressive treatment with methylprednisolone and cyclosporin to prevent further extension and heal the ulcers. So pyoderma gangrenosum starts often with a pustular lesion, often misdiagnosed as an insect bite, but will extend out fairly rapidly, producing often a purple overhanging edge. Ulcers can occur anywhere. The lower leg is the commonest site, but they can occur absolutely anywhere. Spider nevi are common acquired vascular anomalies, and they're due to a dilated telangiectatic blood vessel. So there's a central red papule from which fine telangiectatic vessels emanate. So, as it were, the central papule is the body of the spider, and the fine telangiectatic vessels are the legs of the spider. They can occur in anybody, but they often occur in profusion and of excessive size in people with chronic liver disease. They can also occur in thyrotoxicosis. They often don't require any treatment, but if treatment is desired, then they can be treated by either electrocautery or laser treatment. Palmar erythema is a condition which can occur in pregnancy. It may be idiopathic, but is a common feature of liver disease, particularly cirrhosis. Can also occur in thyrotoxicosis, rheumatoid arthritis, and diabetes. It manifests as erythema over the thumb, over the thenar and hypothenar eminence, and over the lower part of the palm. So Palmar erythema, many causes, chronic liver disease being one of the best recognised. Henoch-Schönlein purpura is an IgA-mediated small vessel vasculitis, and it commonly presents in the skin with palpable purpura, often in childhood, but it can occur in adults, and the palpable purpuric lesions tend to occur over the buttocks, lower legs and feet. So the important thing is the purpura is palpable, and sometimes blistering can occur within the areas of small vessel vasculitis. As well as developing vasculitis in the skin, there's quite often associated sore joints and vasculitis in the small bowel, which can present as bleeding lesions or abdominal pain, and sometimes even in children, intussusception. There may be an associated small vessel vasculitis in the kidneys, but in children the condition usually carries a good prognosis. In adults, however, chronic kidney disease can occur in a minority of adults who develop Henoch-Schönlein purpura. Dermatitis herpetiformis is a relatively uncommon but important immune blistering disease which is always associated with gluten-sensitive enteropathy. Often people who present with dermatitis herpetiformis have no symptomatic gut problems, but everybody will have, if you look hard enough, microscopic evidence of gluten-sensitive enteropathy. So how do they present? They present with an intensely itchy eruption which tends to occur on the elbows and knees, over the sacrum and on the buttocks. Tiny blisters, 2 to 3 millimeters in size, may develop. These are quite difficult to find because they're very often scratched, but if you look on the bottom panel, you can see there are 1 or 2 blisters present in this patient who presented with dermatitis herpetiformis. So intense itching, excoriated lesions on the elbows and knees. You may be lucky to find blisters, but the clue is the distribution. It's symmetrical: elbows, knees, scalp, beard area, sacrum, buttocks. Always associated with gluten-sensitive enteropathy. We can treat it symptomatically with a drug called dapsone. The itching and blistering will stop quickly, but people need to go onto a gluten-free diet to allow them to get off their dapsone and also to diminish the chance of them developing small bowel lymphoma, which can occur in untreated gluten-sensitive enteropathy. In the next few moments, we'll cover the nutritional diseases of scurvy due to vitamin C deficiency, skin problems associated with iron deficiency, vitamin B deficiency, and zinc deficiency. Scurvy develops due to inadequate intake or absorption of vitamin C. Vitamin C requirements are highest in children and pregnancy. Scurvy is actually not all that uncommon in the UK, when it often occurs in people with really poor nutrition, and particularly alcoholics who get most of the calories from alcohol rather than food. The function of vitamin C is to produce normal collagen, and if there's inadequate intake, the following cutaneous signs can be seen. Bruising is very common, particularly on the lower legs. Another common sign is that of follicular hyperkeratotic papules, which tend to occur on the legs and buttocks. Often there is perifollicular hemorrhaging. One of the more frequent signs found is that of corkscrew hairs. These are hairs which are shaped rather like a corkscrew. There's poor wound healing and sometimes even reopening of old scars. Splinter hemorrhages can be seen, and the nails and the gums will become red and swollen. Scurvy is managed obviously by initially recognition and high-dose vitamin C supplementation. Deficiency of iron produces a number of skin effects. So overall the skin is pale, particularly the palmar creases and conjunctiva. There may be inflammation of the angles of the mouth, so-called angular cheilitis, and there may be soreness of the tongue and atrophic glossitis. Iron deficiency can be associated with generalised itching. The hair may become dry, brittle and thin, and the nails may become abnormally curved or spoon-shaped, so-called koilonychia. Zinc deficiency can result in a condition called acrodermatitis entropathica. This usually presents in infancy with a very well demarcated, raw, eroded eruption around the eyes, mouth, napkin area and hands. It tends to occur due to the affected infant having a deficiency of a zinc absorption transport protein, and it is a very disabling condition which ultimately can lead to death if it's not diagnosed. So sharp demarcation of eroded areas on the affected skin, around the mouth, around the eyes, in the napkin area, sometimes eczematous or psoriasiform appearances, sore tongue, mouth ulcers, and rashes then can develop acrally on the hands and feet. And it tends to be treated with high-dose zinc supplementation. An acquired form of zinc deficiency can occur in some children who are being breastfed, and the reason for this is that some mothers secrete a protein which prevents the normal absorption of zinc by the baby. So if that's the case, breastfeeding should be discontinued. The children should be artificially bottle fed and be also given zinc supplementation. There are literally thousands of genetic skin diseases, but two are relatively common and important and seen in general practice and general medical practice: neurofibromatosis and a condition called tuberous sclerosis. Neurofibromatosis is a neurocutaneous genetic disorder affecting bone, soft tissue, skin and nervous system, and there are two types. Type 1 neurofibromatosis, which is characterised by the presence of more than 6 what are called café-au-lait macules, and these are large freckle-like lesions which may be present in the skin folds and in the axillae. There may also be small lesions evident on the iris called Lisch nodules, and there may be multiple cutaneous neurofibromata which present as small, indentable, soft tumours that can occur all over the skin. Neurofibromatosis type 2 tends to be associated with bilateral acoustic neuromas or central neurofibromas and multiple tumours on the brain and spinal cord. So NF1, multiple café-au-lait patches, axillary freckling, Lisch nodules, multiple neurofibromata in the skin. There's no cure for this condition. It's managed by genetic counselling, education, and large troublesome neurofibromata can be excised. Tuberous sclerosis is also a relatively common genetic condition. There are two different genes that have been identified mutated, causing this problem. It presents with numerous hamartomas in the skin, brain, eye, kidney and heart. Individuals commonly present with epilepsy, developmental and behavioural problems and skin lesions. Skin lesions are present in the majority of patients, and they include the following. Small lesions present usually on the facial skin. It's often referred to as adenoma sebaceum, but in fact the lesions are actually small angiofibromas, and you can see them in the upper panel on the cheeks and on the nose. Small red vascular angiofibromas. Commonly there are lesions which occur around the nail folds, and these are called periungual fibromas. Can occur in both the hands and feet. Then things called shagreen patches, which are collagenomas, can develop on the trunk. One of the first signs to develop, however, are hypopigmented areas called ash leaf macules. So they're called ash leaf macules because they're shaped rather like an ash leaf, and they can be identified as one of the earliest signs of tuberous sclerosis, and it's best to look for those in a darkened room with a woods light. There's no cure for this condition. The facial angiofibromas can be treated with topical mTOR inhibitors, and they can be treated by laser. Finally, we'll discuss the skin features of systemic amyloidosis and also the concept of generalized pruritus, that is, generalized itching without any objective inflammatory skin disease to cause the itch. Amyloid is a misfolded protein, and these proteins can be deposited in the skin. A relatively uncommon but exceedingly important condition is called systemic amyloid, and the amyloid is made up of the amyloid P component protein and abnormal light chain immunoglobulin. So this produces what's called AL type systemic amyloid, and it's almost always associated with a plasma cell dyscrasia. So the amyloid is laid down in the skin, and this disrupts the integrity of the upper blood vessels, so that purpura is a very common sign. The disrupted blood vessels bleed easily underneath the skin, so it's very common to get purpura, particularly around the eyes. The amyloid deposit is laid down in the tongue, so this produces macroglossia. Amyloid underneath the flexor retinaculum can produce particularly median nerve compression, producing carpal tunnel syndrome. Again, amyloid under the skin can produce a blistering, which is usually hemorrhagic, particularly, as I say, around the eyes and also on the fingers. So AL amyloid, periocular purpura, macroglossia, carpal tunnel syndrome, shiny deposits under the skin, easy bruising and bleeding, and hemorrhagic blisters. It is associated with the laydown of amyloid, particularly in the kidneys and heart, and it has a very poor prognosis, and the average duration of time from diagnosis to death is about 18 months. The condition therefore has to be treated either with plasma cell directed chemotherapy to stop the production of the AL protein which goes to produce the amyloid, or autologous stem cell transplant. Finally, generalized pruritus is when there is intense, often generalized itchy, but no rash to account for the itch, apart from that due to scratching itself, such as excoriations and thickened skin. It's a not uncommon problem in the elderly, and it's often just due to subclinical dryness. But it can be due to a number of metabolic disorders such as iron deficiency, liver disease, often due to elevated levels of bile acids. It can occur in polycythemia, and often actually the itch then is water-induced or aquagenic pruritus. It can occur in renal failure and also hypo or hyperthyroidism, and globally one of the commonest causes of generalized pruritus is HIV. Importantly, malignancy can be at the bottom of generalized pruritus, particularly lymphomas, so patients need to be investigated thoroughly to exclude all of these metabolic conditions and to look for a covert malignancy.